Hello and welcome to Take the Lead Presents Virtual Happy Hour. We're glad you're here. I'm Gloria Felt, co-founder and president of Take the Lead. We host virtual happy hours on the second Wednesday of each month at 6:30 p.m. Eastern Time. We interview women who take the lead in their own lives and careers. So you have 1 hour once a month to boost your career. It's a quick, easy, and fun way to learn what other smart, interesting role model women are up to too. Please tweet your questions to @TakeLeadWomen or type them into the chat box. We want to hear from you and we'll get those questions answered. Take the Lead's mission is nothing less than leadership gender parity by 2025. Visit www.taketheleadwomen.com to find training programs for yourself and your organization. You can also find mentoring, coaching, role model events, and great content to help you on your journey. That's www.taketheleadwomen.com. Now, make yourself comfortable. Grab a cocktail, a mocktail, tea, coffee, glass of water, whatever you like, and sit back for an inspiring virtual happy hour. Hey, a happy and healthy new year, everybody. I'm Gloria Felt, co-founder and president of Take the Lead, and I am so pleased to be joined by my co-host of this evening, Michelle Weldon, who's editorial director at Take the Lead. And I want to wish everybody a fair, healthy, inclusive, and equitable new year. This virtual happy hour is all about health equity for women, closing the gaps in medicine and healthcare. So, I have a favorite word for this year, and my favorite word this year is intention, or actually I'm going to create a new word. So the grammarians out there can just get ready for it because it's intentioning. Michelle, what are your plans for this new year? Do you have a favorite word?
Well, I'm not making up a word this year, but I have not broken any resolutions yet, and I'm excited that this year I have a new book coming out at the end of the year. So that's
cool.
Keeping me going. I'm real excited.
Congratulations. All right.
Thanks.
Well, we will be diving with our incredible guest this evening into a very necessary and important conversation about health access and disparities for women, particularly for women of color, and how to achieve fairness in healthcare. And also part of that is how to be advocates for our own healthcare needs, right? So these experts can help you understand the framework of healthcare systems, how you fit into them, as well as what you can do to make sure that you're treated fairly. Because we all know our health is paramount, and without it, we can't really achieve anything else. And our mission at Take the Lead, of course, is to reach gender parity in leadership positions across every sector by 2025. And diversity and inclusion are essential within that mission because we know we all succeed or none of us will succeed. So I want to just say, be sure and stay till the end of the conversation today, and you will get some excellent resources, free goodies. We have a PDF of some fabulous Take the Lead columns about women taking the lead in their own healthcare initiatives and startups, as well as a link to a site that has stats and a graphic on the state of women's health around the world right now. Also want to just mention to you, and I'll mention it again later on, that we are going to be doing our 50 Women Can Change the World in Healthcare in 2020. And if all goes well, we'll do it twice, once in Arizona and once in New York. But we do have one in Arizona that's already scheduled for April. So I would just want to ask anybody who's interested, want to find out more about it, to go to the Take the Lead website at taketheleadwomen.com and click on leadership tools. And then that will take you to the 50 Women programs, and you can register right there if you're interested, or you can ask us questions or whatever. You can find out all about it because we'd love to have anyone who's interested in bridging those healthcare disparities and taking leadership in healthcare to join us for that. So I think that, Michelle, we should get to it because so much is happening right now in the public conversation about healthcare from the political candidates, each with their own ideas about how we could get to full coverage for everybody or not, as the case might be, as well as the continuing crisis of access, particularly for the Black maternal mortality rates, social determinants of health, Time's Up Healthcare Initiative, yeah, lots of things that our amazing guests tonight are going to tell us about. So Michelle, you want to do the honors?
Yes, thanks, Gloria. Hi, everyone. We're really lucky to have these two amazing guests this evening. First, we have Dr. Uche Blackstock. She's the founder and CEO of Advancing Health Equity, which partners with healthcare organizations to address the critical factors contributing to health inequity. Dr. Blackstock was recently Associate Professor of Emergency Medicine at New York University School of Medicine, where she was for almost 10 years, leaving to concentrate on her new company. She was also Faculty Director for Recruitment, Retention, and Inclusion in NYU's Office of Diversity Affairs. Dr. Blackstock received both her undergraduate and medical degrees from Harvard University and is the mother of two. Welcome, Uche.
Thank you.
I'm also pleased to have with us tonight Jennifer Block, a journalist and author of her most recent book, Everything Below the Waist: Why Healthcare Needs a Feminist Revolution. Her work has appeared in the Washington Post magazine, The Cut, Newsweek, The Daily Beast, Los Angeles Times, and more. Her first book, Pushed, was named a best book of 2007 by Kirkus Reviews. A reporter with Type Investigations, Jennifer won several awards for investigative work on the permanent contraceptive implant Essure, which has since been discontinued. She's also a facilitator with the Op-Ed Project and the mother of one son. Please start tweeting your questions to @TakeLeadWomen or putting them into the chat box. We want to hear from you, and these experts are ready to answer your questions. Please use the hashtag #TakeTheLeadWomen. Gloria?
All right. Well, I have a favorite first question that I like to ask. And also, it's one of those things that we find that our participants in these virtual happy hours want to know more than anything else is, what's your story? So my first question to each of you is, how did you get to be you? What's your path? What was your path? And if you could take the challenge of answering that in 2 minutes or less, that would be really helpful. So Uche, can we start with you?
Sure.
How did you get to be you?
I don't know if 2 minutes is going to be enough, but essentially, my path really starts with my mom, who was also a physician. I'm a second generation physician, and to be a Black woman physician and to be second generation is like, I'm truly a unicorn in that respect. But my mother's upbringing was very different than my own. She was born to a single mother on public assistance. She had 5 siblings. She had a really, really difficult, challenging upbringing, but she was determined, and with some luck and some mentorship, she made her way to college. She was the first in her family to go to college, and then was encouraged to apply to medical school, got into all of her medical schools, and ended up at Harvard Medical School. And so my sister, I have a twin sister who's also a physician. We both are, we're the first Black mother-daughter legacy from Harvard Med School. But more importantly, our mother really, it was very important for her to give back to her community. She came back to Brooklyn, New York, where she grew up after medical school, and she served the community which she grew up in. And this is a community that was impoverished and that had few physicians that looked like her, but she thought that was very important. And so those were the messages that she passed on to my sister and me. And so I knew that, I didn't just want to become a physician. I wanted to become a physician that made a difference. It made a difference for patients that look like me. And so that's what I'm doing. I did diversity and inclusion work at NYU School of Medicine, but now with my company, I'm hoping to make an even larger impact on health inequities and health disparities. So that's as concise as I can give.
Thank you. It's a remarkable story, and I can't wait to hear more about your new company. Jennifer, how did you get to be you?
That's a tough act to follow. I didn't ever plan to be a journalist, and I didn't even plan to cover medicine or be a doctor. But when I look back, I grew up with doctors in the family. My dad is a retired surgeon, and I had a lot of interaction with medicine as a child. I had asthma, and I had a big back surgery when I was 13 at Boston Children's Hospital. And so I look back and I realized, you know, I already was having some ideas about what good care looks like and what informed consent looks like. But anyway, to make a long story short, I got a degree in English and English education. I was going to be a teacher. And I quickly realized that was not the path for me at that time in my life. It was, I looked like a high school student, so teaching in high school was just ridiculous. And at my last year of college at Boston University, I ended up editing the yearbook. We used to have actual yearbooks. And somehow I became the editor, and I really loved it. And I decided that I really wanted to work on magazines. So I got an internship at Ms. In 1999, when it was still independently owned, based in New York. Gloria Steinem still came to some of our meetings. It was an amazing opportunity. And I was lucky enough to be hired on as an editor and stayed there until after 9/11, when it changed ownership. But while I was there, I kind of became the unofficial health editor. Barbara Finlan had been the health editor. She left and no one was getting the mail. And they asked me, like, is this interesting to you? Do you want to collect the health mail and kind of write up the health column? And I loved it. And across my desk came what became my first book. I got a piece of mail about maternity care and about the rising C-section rate and the problematic use of labor induction, and got on the phone with some people who, you know, those sources who keep you on the phone for 3 hours and sort of lay out the whole thing. And I was hooked, and, you know, 5-7 years later, my first book was published, and it just set me on a path of focusing at this intersection of feminism and medicine that I'm still on.
Incredibly important public service to provide to women and to all of us, to everyone who cares about women as well. So thank you very much for that. Uche, I saw in your recent piece in Lancet that you co-authored with Esther Chu about the triangulation of race in healthcare and what that means for the quality of care, especially for particular groups. Can you tell us more about this idea and what can be done about it?
Oh, sure. You know, I was grateful to have the opportunity to write with Esther about this topic, because I think it's a topic that really hasn't been explicitly discussed within healthcare. And we know that there are significant health disparities that are largely by race. And so thinking about how can our healthcare system and our healthcare education process, how can it really create, you know, a workforce that really adequately represents our patient population. And so, you know, so we talked about this idea, this theory of racial triangulation, where groups, non-white groups in particular, so Black and Asian groups, you know, are often pitted against each other. And that there is, you know, among people of color, this broad term, which is, you know, a little bit problematic, that, not a little bit, is problematic, that there is a hierarchy within that group, and that there, even though, you know, different groups may suffer discrimination, you know, there are differences in the degree of discrimination, and really calling on our Asian counterparts to really think about this hierarchy and to think about, you know, how can they use their privilege within this system to advocate for their Black peers. And so, you know, that was really groundbreaking for us to be able to discuss that. And I think the next time we would love to delve deeper to think about how structurally we can make changes to really support that argument.
Well, first of all, congratulations. It's not easy to get a piece printed in the Lancet. I know that. So congratulations on that. So it means it's really reaching a broad audience of the most influential people in the medical field. So that is fantastic. And also thank you for explaining what you meant by triangulation, because I was very curious about that exactly in that particular sense. So thank you.
So jumping onto that, talking about hierarchies, Jennifer, I know in your research and in both your books and in all your work, you've encountered hierarchies of treatment. So how can all women be certain that they get the best care that everyone deserves? Do you have any ideas on that?
Yeah, this has been a focus of my work for a long time. You know, when we go to the doctor, we expect, you know, we expect we're getting expertise. We expect we're getting evidence-based care, right? We expect we live in the United States. We're getting the best, you know, most cutting-edge science. And, you know, unfortunately, the truth is that we don't always get that. There's a big lag in the time between research and practice, you know, what's in the medical literature, in the Lancet, in the journals, and then how that influences what we're actually getting at the doctor's office. And, you know, I look back at the history of medicine, it's got some ugly bits. It's got some dark and ugly bits, and we're still, especially in women's health, you know, we still see the remnants of those ugly bits, especially in how we treat women when they're giving birth. There's still a lot of routine interventions that are not based on evidence and that are causing harm and that are contributing to a rising maternal death rate and the disparities that we see in terms of race. And so, you know, it's a big burden to answer your question. You know, how do we get the care that we need? How do we get evidence-based care? How do we deal with these hierarchies? And unfortunately, like, people end up having to take on a lot of that burden and be their own advocates and do the research and talk to people and remember that, you know, when you go to the doctor, you are still the authority over what happens. And it should be, you know, the evolution of medicine, you know, we've moved from a place of paternalism, you know, a patriarchal institution that tells us what to do, that tells us what our body, you know, don't ask questions, pat you on the head, listen to us. And we've moved to this place of, you know, shared decision-making and informed consent, and the idea that we take in the information and then we decide. And, you know, a lot of my reporting, unfortunately, is focused on spots for women in particular where our choices aren't always respected.
Wow. Yeah. So much, there's so much in there to unpack, I think. And I think as any woman, I mean, you know, I don't know how many of us on right here have had children and gone through the whole childbirth experience. And I was just reflecting as you were talking on how it was then when I had my children some years ago. And there have been a lot of improvements since then, but there also has been a lot of going backwards in terms of those unnecessary procedures. So it's kind of a mixed bag, I think. Uche, yes, go ahead.
And something, you know, just thinking about sort of just even the nature of medicine itself as a practice is incredibly hierarchical. And that's one of the reasons why we see just within medicine itself, among providers, there's a lot of gender inequity and even sexual harassment. Like, you know, 50% of medical students have been sexually harassed in some form or the other. And so I think for my thought is that sort of culture, it trickles down to our patients. You know, if we are living in a world where there's sexism and, you know, all types of isms, you know, that's going to carry into the way, you know, things are practiced, whether it's explicitly or implicitly. And so in a way, it really shouldn't be a surprise to us. And I think, you know, again, I always think about systemic ways to fix this. But even, you know, there was a very large study in Florida a few years ago looking at outcomes for heart attacks among male patients and female patients. And they found that the female patients cared for by male physicians did the absolute worst, right? And those female patients that actually did well and that were taken care of by male physicians, those male physicians had a lot of female colleagues or had taken care of a lot of female patients, you know? So it's interesting because, you know, that's just on an interpersonal level that we're seeing these these differences. So these are really issues that need to be addressed very early on in training and also within the culture of medicine itself.
Right,
Very
and in
deep
research.
Hmm?
And in research, right?
Yes.
'Cause
Right.
so much of what we think we know, like with heart attacks,
Mhm.
it's all been based on male bodies, right? For years, we weren't even studying female bodies. So,
Right, so what is like the classic symptoms of chest pain? So what is classic? If classic was derived from studies on men presenting with a certain type of pain versus how women present. So what is typical? Like what are we defining as typical, right? So these are things that we really need to think about.
Well, that leads right into wanting to know more about the impetus for you starting your new organization, Advancing Health Equity, Uche. And you know, we've talked about your incredible background and the commitment that you bring to it. What are you hoping to accomplish? And particularly since we know only 4% of all U.S. physicians are Black, and yet
Right.
Blacks make up what, 13%, 14%, like that of the population. So tell us more.
So actually, what I think also is interesting is how I got to the point where I would even, as a physician, think about starting my own company, because it's not something that physicians typically do. If they're going to start a business, it's usually a clinical practice, like they'll go into private practice. Obviously, as an emergency medicine physician, that's not an option for me. There's no real private practice emergency medicine. But really, I started doing it as a result of doing diversity and inclusion work in a very traditional academic medical environment, and really feeling that I could not do this work authentically. So I'm probably not being as explicit as I should be, but sort of the role that I was in at this institution, I was supposed to be working on initiatives to support women faculty. But I was essentially told in no uncertain terms could I actually work on women-specific programming. So even though, so essentially, so basically, it's sort of this situation where you're put into these roles, and to say, hey, we have someone in this role, right? You're basically a figurehead, but we're not really going to empower you to do the work, right? And the same goes for creating an environment where faculty of color, Black and Latino faculty could feel supported. I didn't feel like that was happening and that I was being empowered to do that work. And so I thought to myself, you know, how else can I do the work that I want to do? How else can I make a difference? And so I started doing trainings around racial equity and unconscious bias within my institution. Then I started being asked to do these trainings outside. And then I realized I was pretty good at it and that people would actually pay me to do it. And then so my company was formed about a year ago. And the interesting thing is that now that I'm no longer affiliated with an academic institution, I still get academic institutions approaching me to do work with them. So these are organizations that actually want to do the work. And I feel like I can have a larger impact working externally because I can be a little bit more innovative. I can push the envelope a little bit more. Whereas internally, I felt almost scared. I felt scared to say this is what I think what we should do, because I actually felt scared that I would be pushed out, which, you know, I feel like in a way is what sort of happened, right? I mean, it was the culture that was not supportive of the work that I needed to do. And this is not uncommon. And I was not the first woman of color to be in this situation.
Right. Yes, this is not. This is definitely a larger conversation about workplace cultures and women in general.
Right.
To get back to healthcare.
Right.
Right. And what you could do with your fear, what you could take from that to create. Jennifer, in your new book, Everything Below the Waist, it's so deeply researched, and I completely respect it. And it's all about the history of health and equities for women. So why did you write that book? And what do you think is the biggest challenge for women seeking fair healthcare treatment?
Well, this book really grew out of PUSH. You know, like I said, I when I was working on Pushed, I was a bit naive. I was like in my 20s. I wasn't thinking about pregnancy. And I was sort of shocked that standard maternity care was what involved so many interventions that are not evidence-based, and were leading so many women to cesareans that weren't originally necessary, and also were, you know, railroading women into things they didn't want, not respecting their choices. And I was a little naive about, like, you know, healthcare is, it's political. At Ms., I was covering abortion and contraception and things that are obviously political and politicized. And then I realized, oh, like, this is also political. I came out of that experience and looked up and started hearing from women who'd had hysterectomies that they felt had been unnecessary, that they felt had affected them in ways that they weren't told about. They weren't told they would go into premature menopause. You know, they weren't given the information. I started also looking into, you know, interventions that we as feminists embrace as empowering, and in our narrative, we've given them status of, you know, liberating us, like the pill. And I looked more closely at the pill specifically and saw that, while yes, it was liberating, it also is having a large impact on our health. And we're having trouble having this conversation because of the politics. And I also wrote this book because I was really interested in the feminist health movement of the 70s, which is really, I think we should think of it separately, or as like a separate branch of the women's movement. I was very curious about it because there was this spirit of curiosity and reverence about the female body and physiology, and this spirit of, you know, take back your body and take back that authority over what happens to your body, especially in, you know, when interacting with medicine. You know, and so the movement behind our bodies ourselves, and you know, that led us to resurgence in midwives and home birth, and also like gave us the drug labeling, the transparency that we expect now. This movement did so much. And it kind of, I was very curious about like what happened to it, because I was wondering, like, well, where the feminist health movement in the 70s was actually very skeptical of the birth control pill, and led stormed the hearings in Congress. And while they recognized it was liberating, they were still concerned about its impacts. And yet today I like was seeing a kind of like silence around that. So I was very curious about that movement and how we've associated medical technology with empowerment, and how that's impacted you know, how we interact with the medical system. What was the next part of your question, Michelle? I kind of lost it.
Well, I think you covered a lot there.
Yeah.
Yeah, thanks for that.
You sent me on a little like a journey, a journey of remembering of that time, and the first time I saw Our Bodies Ourselves as a little paperback booklet in a women's center at a university where I was, it was quite a heady time, all right. So I think part of the answer is, in some sense, we became mainstream, and that's always what happens with social movements. Hey, listen, we are having such a great conversation here that we're already pretty much here at the middle point of our program. So I just want to remind people that this is Take the Lead's virtual happy hour with our incredible guest, Dr. Uche Blackstock, CEO and founder, excuse me, of Advanced Health Equity, and Jennifer Block, journalist and author of Everything Below the Waist. And that tonight we have some great free resources for you, including a PDF of some key Take the Lead blog posts, and a link to a graphic on the state of women's healthcare that you'll be able to download. And we're also want to make sure that you have links to Dr. Blackstock's article that we talked about, and Jennifer's book and other resources that we talk about, so that you can check out and find out more about them as you wish. And also that you hop over to taketheleadwomen.com today and every day for free resources for Michelle's award-winning newsletter and blogs that will help you break through barriers to get to the career of your highest intentions, and will help your organization reach its diversity and inclusion goals and deal with some of those cultural issues that we're talking about today. And finally, before I go right back to our guests, because we have a whole lot of questions, and I want to just take questions for the rest of the program if we can, there is the 50 Women Can Change the World program, and it's an intensive program of training, coaching, career planning, and cohort building by sector that we do, and it's a super powerful program. We'll be holding a healthcare cohort in Phoenix and a healthcare cohort in New York during the course of this year. So if you have any interest in that, if it fits your particular career or something that you want to be part of, go to taketheleadwomen.com, flip over, click on the leadership tools, and then you'll be able to scroll down and see the 50 Women Can programs and find out all about it. And you can go ahead and either nominate somebody, or you can nominate yourself if you have an interest in it. And that doesn't mean you're signing up for anything. It just means we'll get in contact with you and give you more information if you want it. So please feel free to do that. Companies who are committed to gender equality can also sponsor these programs, and we would love to have you on board, because that's what enables us to make them affordable for people. So you can just email me at takethelead@taketheleadwomen.com if you would like to do that, or tweet me at Gloria Felt. Okay, I think that was the unpaid political commercials that we had here today. And I want to go back to our guests. And Michelle, can we start with some questions from our viewers?
Yeah, I have a question here from Melody, who asks, I'm a first-year medical student, and one of the professors seems to treat women differently, not calling on us as often, and even not as pleasant to us in the hallways before or after class. Should I report him? That's likely for you, Uche.
Oh, well, I'm sorry that you're having that experience. It's not surprising at all. And I'm wondering if you would think about speaking to your classmates and maybe getting together some descriptions of the different experiences that you're having with this professor, and then even finding a faculty member who is an ally to help support you and approach the administration about this. But I definitely think it's something that, you know, should be brought up. I understand that your concerns because you are vulnerable as a student, but see who you can find within the administration to be an ally to you. And then also there's power in numbers. So if you can get some of your peers together to also share their experiences, that would help as well. And best of luck to you.
Great, thank you.
So I know that I saw a text that I cannot read because I'm using my phone. So if Jovanka, if you wouldn't mind either putting it in the chat so Michelle can read it, or text it to her, that would be great. Meanwhile, Courtney, we have a question from Courtney, who says, I've heard that Time's Up Healthcare is doing, I've heard what Time's Up Healthcare is doing to change the status quo, but what do you think will shift culture for women working as nurses and doctors? That's a big question. What do you think will actually shift the culture instead of just nibbling around the edges? Either one of you can answer that one.
Jennifer, you can go and then I'll add.
Well, I think you hit on it earlier, Uche. I mean, I think we've realized in the last couple of years with Me Too and Kavanaugh and everything, you know, that we still live in a really sexist culture, and there's still a lot of sexual violence and sexism, and we have a respect problem. We don't respect women. And so these are like big cultural problems. And of course, yeah, we're gonna see them in medicine because we see them everywhere. So the solutions are big. I don't know.
No,
let me just ask, can I just ask both of you to address, I mean, do you think that simply having more women in the system will make a shift?
No, I don't.
No?
I don't think so. And there's actually a really good article out recently. I'll see if I can find it that talked about even having like women CEOs. That doesn't necessarily change the culture. It really has to be a shift in everyone's mentality, right? And everyone sort of thinking about gender equity. I think that what's been pivotal about the last few years is that it's actually becoming a point of discussion in the public discourse, right? And I think that we're having people that are feeling braver about speaking out about the experiences that they're having. So I think that definitely is a shift. And so we need to do, the other shift that needs to happen is from the discussion to action. And I think that is definitely going to take a lot more momentum and take significantly more time. But I think that, as long as we have, mostly women on our side and our male allies, I think that we can really make a difference. But I agree, it's a tremendous effort, and it's definitely going to take time. Yeah.
Just to push on that a little bit, I mean, what do you think we can do to help women use or be mindful of the opportunities that we have as women if we're in those systems? What are the small things we could do on a daily basis that might help shift that culture?
Yeah, I mean, I think, mentoring each other, even in meetings, like supporting each other, say, oh, if someone mentions a point that another woman has already mentioned, say, yeah, like so-and-so just said, giving them credit for that. I think those are the little things. And then, speaking up for each other and really supporting each other.
I just got a new question here from Laureen, who says, I try to avoid going to the doctor because it's so expensive, and I prefer to treat any symptoms I have from advice I get online. Is this a good practice? And I think I can tell from your facial expression what you might say, Uche.
Oh, yeah, I mean, it's easy for me to say, as a physician, that it's not a good practice. I definitely understand, because I don't run to the physician either, like even as a patient. I definitely get that perspective. I do feel like, the internet is not a bad thing. Like you can go on it as a patient to get informed, but I think to like self-diagnose yourself probably is not ideal. But I think to go into a visit with having information and wanting to make a shared decision-making with your provider, I think makes total sense to me.
Wait, do you want to add anything, Jennifer?
Well, I just want to say, I mean, I hear this a lot, and I think, it points to a problem that a lot of people, a lot of women especially, have, there's been a trust that's broken. They feel like they go to the doctor, they're not listened to, they're dismissed, and also maybe like they're not offered a treatment that's helping, and so they end up turning to Facebook groups. A lot of people share information that way. They end up turning to, the big wellness, which, sometimes things help and often they don't. But I think like the problem is that, our system is really difficult, right? It's like, it is a headache to go to the doctor. It's expensive. It may not get covered. That is a huge problem. But then there's this other thing that I think is related to gender, that there's a phenomenon, and I've heard it from so many women I've interviewed, that they just, it's triggering. It's triggering old trauma to go to the doctor because they have past experiences where they were not listened to and not helped and maybe harmed. And so they avoid it. And I think that's something we need to pay attention to, and that medicine needs to pay attention to.
Thank you, Jennifer, for mentioning that. And I wasn't trying to minimize that concern at all. And I even had that experience where, even I'm an emergency medicine physician, so I don't see the same patient all the time, but I get patients that I see in the emergency department asking me, do you have a practice? Like, do you have a practice? Like, can you be my doctor? And I think it's because like I'm very, very mindful of making that connection with my patients. And I think they can see that. And it's usually female patients that ask me this as well. So I definitely appreciate it. It's the healthcare system is broken, right? But then also on an individual level with providers, there's definitely that, patients are feeling like we're not listening to them. And I think that's very real.
Well, one of the things, Uche, that prompted Take the Lead to offer our 50 Women Can Change the World in Healthcare is the statistics that something like 80% of the healthcare workers are female, but when you get to the actual top,
yeah,
it's like, the administrators, the people who make the decisions, who allocate the resources, it's more like it's flipped. It's like 20% female versus so we want to help change that. And so I'm all ears to hear your thoughts about what are the kinds of things that you in your wildest dreams would like to see women who are in healthcare have the opportunity to learn about that might help them flip that statistic.
Yeah, I mean, a few of the things are there definitely needs to be like formal mentoring and sponsorship programs for women in healthcare. Like we know that mentorship and sponsorship is incredibly invaluable to career development, but we don't see women don't have the same opportunities as their male counterparts. And so I think the only way to really make sure that happens is to really formalize these types of processes. So even thinking about even within academic settings for promotion, thinking about the criteria that we've traditionally had for what is worthy of promotion. A lot of it is what typically is sort of created by men, right? And we need to sort of revise that and think about how can we be more innovative and how can we be more inclusive in terms of thinking about criteria for promotion and leadership. So those are just a few of the items. And then and then thinking about who is in leadership, right? And being very intentional about ensuring that we have diverse representation of people with diverse perspectives as well, because what happens is we get self-cloning, right? We get people who are, they're choosing, once they retire, the person that they were mentoring, assumes the position. That person looks just like them, has the same, perspective as they do, and it kind of just self-perpetuates itself. And so we really need mechanisms in place to prevent that from happening. And even I think about chairs of departments, like even having like a tenure limit for them, right? Like to have someone as chair of a department for 30 years, like that's kind of ridiculous, right? And so thinking about just sort of innovative ways to ensure, diversity and inclusivity.
Mm-hmm, mm-hmm.
Right.
Jennifer, any thoughts to add there? I'm sorry, Michelle.
No. Good.
Mm-hmm.
I just was intrigued by this new question Javanka sent over from Sasha, who says, my OBGYN wants to schedule a cesarean section for me. I am 30 weeks pregnant and I don't want to do that. What do you suggest? I think I already know your answer, Jennifer, but please. And Uche, please.
I just wonder why, like, did she ask her OB why? Like, is there a medical indication for it?
This is all I got.
Oh, yeah.
I have so many questions too. Yeah. But I think, what I would say to people is if they're with a physician and they're always getting a little voice in their head that's saying like, I don't feel comfortable here. I don't feel like I'm being, things are being explained to me. I don't understand. I don't want this to happen. Like, it's hard. It's so hard in the system, but I think it's worth it to find someone who is going to respect your intelligence, your body, your choices. And the women I interview who have had traumatic experiences or, have had complications from treatments or devices. One of the most common things I hear is, I wish I had listened to that voice in my head, or I wish I had done my research, or I wish I had done more, I wish I hadn't just like accepted what was convenient. So it is worth it, I think, I've gone to great lengths to find providers who respect me. But it's also really hard, and it's a burden, and we're all not equally equipped to deal with that burden. We all don't have the time and resources to go looking. And I know that women in late pregnancy, it's especially hard. And Uche, maybe you can talk about this, but I've heard from women who say like, no one will take me after a certain number.
Right. Yeah. I think a lot of OBs are less inclined to accept you as a new patient if they haven't been caring for you since the beginning of your pregnancy. Yeah. But I also want to add just on this discussion is that even, women of color, specifically Black women, even across socioeconomic background, right? In terms of maternal mortality outcomes, it doesn't improve your outcome if you are middle to upper class Black woman. Like you still have significantly worse outcomes than white women, even with a lower, education level than you do. So, sometimes you would think that certain things are protective, right? Like, having more, having more wealth, but it's not. And so that's actually something that, is very troublesome.
Right. And it points to institutional racism and bias. And so, if people feel that, they're not imagining it.
Right. Really. Yeah.
So if you were designing the healthcare system, what would it look like? I'd love to hear that from both of you. What would our healthcare system look like if you were in charge of the world?
Okay, I have a few ideas.
Okay, good.
I mean, I do think one thing I would do is, speaking of hierarchies, our history has made it so that medical doctors are sitting atop the hierarchy of knowledge and authority about bodies and healing. And while they do have a lot of expertise, and we need them and we need that expertise, we also now know that, acupuncture has benefits for pain and depression and anxiety. We know that meditation work, like all these things that we've thought of as alternative and have often been labeled worse than that. Now, we're seeing research showing that actually they have a place. And so I would even out that that pyramid and make it so that, we have more experts to choose from and more ways of knowing to choose from. And on that note, I would say that, midwives, the history of medicine is that it was really a hostile takeover of midwifery. And it didn't do women or babies the service that we sort of think of in the narrative. Like, we actually saw maternal mortality and infant mortality rise for a little while before we had antibiotics and surgery, because instead of women giving birth in homes with midwives who had expertise, now they were in hospitals where physicians were going from, doing autopsies to touching women, and we caused infections and deaths. And so, now we do have midwives again, but they are marginalized. It's difficult to get your insurance to cover midwives. There aren't as many, so it's, you have to work to get to find one, etc. So I would flip that. We sort of have it backwards. Like, we have a lot of OBGYNs and very few midwives, and we really need to work to tip that so that we have OBGYNs with expertise for the high risk pregnancies and to do the surgeries when we need them. But really we need the experts in physiologic birth as frontline providers for the vast majority of birthing people.
Yeah, I actually really agree with that. Even as a physician, like this hierarchy within healthcare, I think, and a lot of physicians will probably get upset with me and have gotten upset at me because I've tweeted about this before, but caring for a patient and caring for like the whole person requires multiple members of the team. So nursing, social work, physician assistants, acupuncturists, so many different types of people, but we have this very traditional sense of what it means, what medicine means. And, it's very, very westernized also. And so I think that we need to sort of get out of that way of thinking. I would also say that we need to think about ways structurally to get a more diverse workforce, right? So even starting from the kindergarten through 12th grade pipeline, like how do we get more Black and brown students into pre-med and expose them to healthcare and into different, healthcare related professions, because that's also a factor in helping to reduce health inequities as well. And we talked about what we could do to help get women into leadership positions, but that's also starting even earlier in education, the educational process.
Well, it would be wonderful to see your hopes and dreams come true. And we have a lot of work to be done. So, do you have any other questions from folks, Michelle? Are there any other questions we need to take?
Do we have time for one more?
We have time for one more. We do.
Okay.
Yes.
So this is from Flo, and she says, I just got a large bill from my healthcare provider for tests that are not covered by insurance. I already paid the visit copay. What should I do? Call your insurance agent.
Call your insurance company. And then if the insurance company says, look, we're not, your plan is not eligible for this, maybe consider calling the hospital or wherever the bill was incurred. And I think a lot of these hospitals have departments that deal with, people who are in some sort of financial distress. But obviously, this is a huge issue, right? This is a huge issue. Surprise billing, people getting bills for incredibly large amounts that they're unaware of. And so, again, another issue that needs to be addressed, and that's getting a lot of press recently as well.
Especially with the MLK 50 and ProPublica work. Right.
Oh yeah,
because our good friend Deborah Douglas and Wendy Thomas are very good friends of ours.
Wonderful.
Amazing reporting there. Yeah, I just say call, ask questions, call again. It's infuriating. I just got a bill for, I went to urgent care. I called the insurance company. I said, I'm out of state. What do I do? I think I'm having an emergency. Oh, any urgent care? And now they're telling me, oh, we don't cover urgent care. Yeah. It's like, everyone has a story, and it's absolutely infuriating. And also we have an election coming. We have got to get rid of the system. Indeed.
And in terms of asking questions, we need to ask questions of people who are running for office, who are running for any office that has the opportunity to have some impact on the availability of healthcare to people in general. I mean, in my experience, and I would just add one thing to what you both said, which is that generally speaking, first of all, do go over everything they're saying about what you owe and make sure that you agree with that cost. But also, for the most part, you can usually negotiate a payment plan if you need to do that. Almost any healthcare provider will make some kind of accommodation for that, so that it doesn't solve the problem, but it might spread the solution out a little bit so that it's easier to deal with. So I want to make sure that people know how they can find you both, and your book and your article and everything else. How can people find you, and what's the one big takeaway that you would like people to have? You could give them one takeaway from the wisdom that you have brought to this discussion. What would it be? So Jennifer, can we start with you? How do people find you, and what's the big takeaway you'd like to share?
Sure. So I have a website, jenniferblock.com. I'm on Twitter at writingblock, WRITINGBLOCK. I've jinxed myself.
I have that.
I'm on Instagram and Facebook as Jennifer Block Author. You can look for a forthcoming feature in long reads. And I think that my word for 2020 is autonomy, and, make sure that what happens to your body is something that you agree with.
Thank you. Wonderful. Uche, how do they find you, and what's the big takeaway you want people to have?
So you can find me on Twitter at dr_UCHE_BEE. So, or just put my name into search, Uche Blackstock. And my website for my company is www.advancinghealthequity.com. And my take home today is that is to be brave, I never thought that I would be a CEO of my own company. I thought that I was only going to follow a certain track, and then certain things happened in life, and I started thinking about other options. And so I just want to encourage people to step out of any zone of fear that you may be in, and to think big and be brave.
Great advice.
That's terrific. I have a fun question now for both of you. What is your go-to song or quote that gets you revved up and keeps you revved up? Who wants to go first?
Oh my gosh, hard. I'm looking at my phone now.
And you can even sing us a few bars.
Yes, right.
Who wants to go?
Let's see.
I have a 6-year-old and he has taken over my Spotify. I mean, I just listen to his playlist all day long. I don't even.
If you're
does it
happy and
get
you know
you
it, clap
going?
your hands.
For me, anything by Lizzo. I love her and her music, and I think she's amazing and inspiring. So, yeah.
Love Lizzo.
That's great. That's fantastic. Well, we cannot thank you enough for being with us tonight. I want to make sure that everybody who has been with us also knows how much we have appreciated you for joining us. Thank you for your questions, and thank you for being part of this conversation. I want to make sure that you have downloaded the items that we mentioned to you earlier, that just be sure that look in the chat, and we'll also be sending out the links to everybody who signed up for the virtual happy hour, because we know sometimes people sign up and then they don't have an opportunity to actually participate in person. So we'll be sending all of these links out and making sure that you have access to all of these great free resources that we wanted to provide to you. Thank you so much to our guests tonight, Dr. Uche Blackstock and Jennifer Block. You are now an integral part of Take the Lead's network of all persons working for gender parity by 2025. And I have to say that you're both you just can expect to be asked to be advisors to our 50 Women Can Change the World in Healthcare programs, because we need you. And we hope that you will join with us and help us reach out to your networks and make sure that people know about this program, and will help us just make sure that we're making it the most relevant possible and doing the best that we can to advance all of these values that we talked about tonight, including diversity and inclusion, and dealing with the implicit biases in the system and changing cultures where that's necessary. So please, everybody out there, go to our website, taketheleadwomen.com, to learn more about how we can help you and your organization achieve gender parity in leadership, and share with people on social media. We can't spread the word too much. What else do I have to say? Anything else, Michelle, that I forgot?
A big thank you to everyone listening, and to our guests, and to you, Gloria, for making this all happen. Really appreciate it. It was a great way to spend time.
Indeed,
learning.
it was. And should we reveal the surprise? Whoops.
Is that the surprise?
Okay.
Go ahead, you reveal the surprise.
My phone's surprise was, you're out of battery, lady. That was my phone's surprise. Yeah, right. No, we've had a great almost 6-year run of virtual happy hours, and we're going to be switching to podcast mode from here on out. So we particularly thank the guests tonight, and you, Michelle, for making this possible, and Jovanka, who's not being seen on the screen, but who has handled all of the technical aspects of it. It's been fantastic. All of these will remain available to people on YouTube, and we'll be tweeting them out and everything else. But we'll be switching to podcast mode after this virtual happy hour. So thank you all again. It's been fantastic discussion.
Thank you.
Thank you.
Thank you.
Thank you for having me.
Thank you.
Thanks for joining Take the Lead Presents Virtual Happy Hour. Be sure to tune in again next month. Remember, it's the second Wednesday of every month at 6:30 p.m. Eastern Time. 1 hour, once a month, to boost your career. Until then, power to you.